Eye procedures are delicate and precise, and they are performed on the external and internal structures of the eyes. Most eye procedures are done under monitored anesthesia care or MAC, so the patient will be required to stay still. Please review the outcomes for this chapter. The main structures of the eyeball contained within the orbital cavity, also called the bony orbit. There are 7 separate bones that come together to form the orbit. They are the frontal, lacrimal, sphenoid, ethmoid, maxillary, zygomatic, and palatine bones. The rim serves as protection, and the optic nerves enters the posterior orbital cavity through the optic foramen. The lacrimal apparatus produces tears. Tears are composed of many chemicals and continually bathe the eye and protect it from dehydration and infection. Emotional tears have a different composition than those arising from irritation and pain. There are many external structures of the eye. The eyelids are fibrous connective tissues with skin used to protect the eyes from injury and light. Each juncture of the eyelid is called a canthus. Therefore, each eye has a medial and lateral canthus. The tarsal is a plate of dense fibrous tissue that forms the main scaffolding of the eyelid and gives it support. The conjunctiva is a thin, transparent mucous membrane that lines each eyelid and covers the sclera. Six muscles attach the sclera to the bony orbit and move the eye. 4 rectus muscles and 2 oblique. The eyeball is also called the globe. The external layer or tunic of the cornea and sclera. The cornea is a clear tissue, the dome on top of the eyeball where the light enters and is refracted, allowing images to be focused on the retina. The sclera is a thick white fibrous tissue that encloses about 3/4 of the eyeball, and the limbus is where the cornea and sclera meet. The choroid is a vascular middle layer or tunic that lies between the sclera. The ciliary bodies are an extension of the choroid. They are smooth muscles which the suspensory ligaments are attached, and those ligaments hold the lens in place. The retina is the innermost layer of the posterior globe. The iris is a pigmented membrane composed mainly of tissue muscles that surround the pupil. The action of the muscle fibers causes the pupil to close or open, allowing the amount of light to enter. The pupil is the opening of the iris and may appear dilated or constricted depending on the action of the iris. The lens lies directly behind the iris and is a biconvex clear structure encompassed by a transparent capsule. The lens is naturally flexible. It bends light rays and focuses them on the retina, creating an image to be sent to the brain. The space in front of the iris is called the anterior chamber. The space behind the iris and in front of the lens is the posterior chamber. Both chambers are filled with a clear aqueous humor. The pupil allows fluid to pass between the 2 chambers. And the space between the lens and the retina is more gel-like, and this area is known as the vitreous body or chamber. The visual field in this area we see or focus on a single point. Vision is usually binocular, which means each eye has a nearly separate visual field and the 2 are brought together in the brain. Refraction is the bending of light rays through a transparent medium. The focal point is a location where the light converges, and accommodations is the process of focusing. Most patients with impaired vision are older adults, so they require individualized care that takes into consideration the environment, the room temperature, the choice of anesthetic, and special written post-operative instructions. Since the majority of the patients are under conscious sedation or MAC, keep the room as quiet and calm as possible. Patients will tend to pull away from the surgeon when startled or frightened. This reaction can lead to injury of the operative's eye. There are many medications that are specific to ophthalmic procedures. They can be instilled or injected in the eye before, during, and after surgery. The surgical technologist must label all medications as soon as it's distributed onto the field. During most surgeries, there will be a number of similar looking drugs. Mydrotics such as neosynephrine are used to dilate the pupils. Psychopelagics such as atropine and tropicamide are used to paralyze accommodation. Miotics are used to constrict the pupils. These include myostat and pilocarpine. Topical anesthetics such as testosterone numb the eye. Helon, Provisc, Viscoat, and Duravisc are viscoelastics, and they have several functions. They are used to lubricate and support and replace a vitreous humor. Balanced salt solution, or BSS, is used to irrigate the eye. Mannitol is used by IV from anesthesia and to decrease intraocular pressure. Mitomycin is an antimetabolite used to inhibit scar formation, and fluorescein used topically is a stain used to see defect to the cornea. Most eye procedures can be done with mild sedation and numbing drops to the eye. Some procedures are done with a regional block and moderate sedation, and on all pediatric patients are given general anesthesia. One of the methods for blocking the eye is called a retrobulbar block. The patient is anesthetized just prior to the administration of the block because the block itself can be very uncomfortable. Then the patient is awake but sedated during the procedure. The most important aspects of positioning the patient during ophthalmic procedures is to stabilize the head and protect the patient from injury. Many ORs use an eye stretcher to transport the patient and perform the surgery directly on the stretcher. The patient will be supined with the head in a donut and often tape across the forehead to stabilize the head. A pillow will be placed underneath the knees and the arms will be tucked. Some surgeons will use a wrist rest for their hand during surgery. Eye preps are vary from place to place depending on what procedures are being done. In the prep just for the eye, such as the cataract procedure, the prep is very small. A 5% betadine solution would be instilled into the eye. Also, instilling numbing drops is considered part of the prep. BSS, or balanced salt solution, is used to rinse the eye if necessary. There are also many different ways to drape for an eye procedure. Often the drape will be a self-adhesive with fenestrated plastic section for the eye. A fluid pouch may also be used. The surgical technologist should examine each instrument for damage before and after use. These instruments are very delicate. The majority of eye surgery would take place in the dark. The surgical technologist must keep a neat table and know exactly where each instrument is located. Many ophthalmic procedures are done under the microscope, therefore the field of vision is magnified but limited. The surgeon cannot look away, so the surgical technologist must be prepared ahead for each step of the procedure. It's a good idea to limit caffeine intake so your hands don't shake, and be careful not to bump or move the microscope. The scope should be adjusted for height and placement over the patient by the surgeon before scrubbing. The microscope is seldom draped. Electrocauteries used on ophthalmic procedures can be unusual. Electrocautery used on ophthalmic procedures can be the usual ESU electrosurgical unit, or BOVI, or a handheld battery unit called the eye cautery. Eye sponges are lint-free and commonly called Weck spheres. Ophthalmic sutures are very small. A 10-0 nylon is commonly used. Not all facilities count needles on suture that small, so check at each facility. Ophthalmic dressings range from none at all to a simple iPad or a shield. Only lint-free microsurgical wipes are used on instruments. It is very important on eye cases to reduce lint. It can be very harmful in the eye.